Hi, everyone. So we'll get started now. Welcome to this first session of the Virtual Introductory Summer Course in Ophthalmology, or VISCO, for 2022. My name is Cody Lowe. I'm one of the resident physicians in ophthalmology at the University of Ottawa, and I'm also one of the co-course directors for VISCO this year, and also the resident advisor for COSIG. And it's my real pleasure to be one of the moderators for today's session and welcome you to the course this year. So because it's the first session for our course, I just had a few slides introducing the course and the team that helped put all this together for you. It's really nice to see such a nice turnout for this first session on a Sunday afternoon or whichever time zone you're in. And I recognize that some of you, come from a diverse range of backgrounds. We have a lot of Canadian medical students interested in ophthalmology, Canadian residents in family medicine, emergency medicine, but also a lot of trainees coming internationally, either from the United States or overseas. And so I just wanted to introduce our group, the Canadian Ophthalmology Student Interest Group, or COSIG. We're a group of Canadian medical trainees made primarily of medical students who really helped this whole operation run, who are interested in ophthalmology and put on a number of events related to ophthalmology in Canada. And so here are just some of the initiatives that COSIG runs throughout the year. And so if you enjoy VISCO and some of the things you learn from this course, I urge you to check out some of the other events that COSIG runs throughout the year. And today's our first session of the course, and I'll introduce Dr. Nguyen in a second here, who will be giving us a nice overview of an approach to a patient with an eye complaint. But I just wanted to highlight that we'll be running a number of other sessions for VISCO throughout the summer. That'll be touching on a range of other topics that are really integral to the practice of ophthalmology. So over the course of the summer, we really urge you to consider attending some of these other sessions. We have a really excellent lineup of speakers this year that come from the University of Ottawa and also the University of Toronto. And these are all really experts in their respective fields. And so they're going to be giving some really great talks on these various topics. And I just want to also give a shout out to the members of the organizing committee for VISCO. Many of them are here today in this call. For putting in a lot of work over the past few months, putting this course together for everyone. So a big shout out to them. I also wanted to give a thank you to the U Ottawa Department of Ophthalmology, my residency program, for supporting the course this year. In particular, I wanted to acknowledge Dr. Dana Albrecki and Dr. Michael Dolan for acting as faculty advisors for this year's course and helping us be able to put this on for you all this summer. And Dr. Albrecki will actually be giving a lecture next week on OCT. So I just wanted to acknowledge their contributions to this year's course as well. And so now on to some perhaps more fun aspects of the course. Despite all the learning that you'll be doing over the next couple of weeks, there also are some really nice opportunities to win prizes as part of the course. So for every session, there will be an interactive portion using a platform called Kahoot, which Dr. Nguyen will introduce in a second here. But basically, this allows you to answer questions related to the course material in a very low stress and a low sort of barrier way. And by answering these questions, you'll accumulate points. And at the end of the session, if you place in the top 10, we'll be randomly selecting two participants to win one of two $25 gift cards. And so at the end of the session today, we'll announce who those winners are. And if you send us a screenshot, we'll send you your prize. And so hopefully a little bit of extra motivation to keep focused during the session today. And so without further ado, I just wanted to introduce our speaker for this first session of VISCO 2022. It's a real pleasure and honor to be able to introduce Dr. Michael Nguyen, who is a PGY4 ophthalmology resident at the University of Toronto. He completed medical school at McMaster University and is currently serving as the co-chief resident at the University of Toronto. He is currently serving as the president of the Council of Canadian Ophthalmology Residents, or CCOR for this year. And he is highly interested in leadership and medical student education and is actually the founding course director of VISCO when it ran in its first iteration last year, and is serving as co-course director alongside me for this year's course. And so he'll be speaking to us all, giving us just a really nice introduction to ophthalmology and an approach to a patient with an eye complaint. And so without further ado, I'll hand it off to Dr. Nguyen to take the stage here.
Perfect. Thanks so much, Cody. I'm just going to get started with my first of a few presentations. Thank you everyone so much for coming to be here. Really a pleasure to be spending my time with you today. Thank you for coming and thank you for learning with me today. Today, we're going to be doing a few different types of presentations. The first one, I want to give an overview for the approach to the patient with an eye complaint. Now, there are, as Cody said, many levels of trainees here, but I think that no matter what level of training you are, it's always important to understand the basics of whatever field that you're in. And ophthalmology is no different. It can get very complex very quickly, but if you're able to break down ophthalmology back down to its bare building blocks, you'll find that it's much more simple. So for some housekeeping, Cody mentioned already, we do have some prizes for Kahoot. So try and pay attention to this lecture. This is where the questions will be based off of. And, for my first presentation in this hour, my learning objectives really are to understand the high yield anatomy of the eye, because I think that to approach different complaints in medicine, you really should have a strong understanding of the basics. And the basics for ophthalmology really come down to the anatomy. And it's not just the eyeball, that's one structure, but there are many structures inside the eye, and understanding the eye and its various structures will give you a sense of how to approach patients when you see them in the clinic and on your examinations. I'm also going to demystify reading and writing and ophthalmology consult notes, because I know that medical students and family medicine residents and emerge residents sometimes can't understand our written notes. So I think this is very important to be able to interpret and for you to be able to write your own notes if you're going to be coming to elective with us, or if you are a junior resident. So like I said, the best way to approach a patient with an eye complaint is to really think about the anatomy, because the anatomy will guide our approach. So today we're going to pretend that we're in the resident emergency clinic, and in the second hour, we're actually going to blast through 15 cases that are very commonly seen presenting to the emergency room. And this is a good level for you to be at. You're not in ophthalmology yet, or you may be, but if you're not, and you're a family medicine doctor, you need to be able to understand the very basics of our field. So some common diagnoses that we see often in ophthalmology are iritis, we see corneal abrasions, we see glaucoma, and we see posterior vitreous detachment. I mean, these are quite possibly comprising of about 70% of all the things you'll see in most ophthalmology clinics. So, for bang for your buck, you kind of want to hit these four and really get a good, strong understanding of it. Now, I'm not going to talk to you today about different management of different, diseases. There's lots of good resources for that, but I want to conceptually get you to understand these diseases, because when I started, something as simple as iritis for me now was very complicated, and I did not understand how iritis worked, what the classifications were, because I didn't understand the anatomy. So I really want to help you understand the anatomy today. So this is a picture of the eyeball. You'll see this in many textbooks, including the one from my university. And there are a lot of complicated structures, right? There's a lot of words, okay? A nice picture, but there's a lot of words, right? There's different things: fovea, centralis in the macula, the sheath of the optic nerve, vitreous body. And when you see all this, you can't possibly sit down and try to memorize every structure, because there's no foundation for you to put this all in. So I like to simplify it and take away all the words, so you're left with a picture, okay? In ophthalmology, as you know, it's a visual specialty, and we like lots of pictures. So try to think about this eyeball as a picture, and we're going to simplify it even further into the picture you see on the right over here. Okay, so I'm just going to draw with basic colors what I think of when I see the eye. And even though I'm almost, in my last year of training, and I'm going to be graduating in a year, this is still how I think about the eye a lot of the time, in very simple terms. So when I think of the eye for me has three layers, okay? There's three layers in the shell of the eye. The outermost layer, okay, comprises of three parts, okay? So we have the sclera, and that is kind of this part over here, the white of the eye over here that you see in your own eye. We have the cornea, which is the clear part of our eye, which is the clear part of the eye, and then we have the sheath of the optic nerve, okay? And remember that the dural sheath back here is actually a component of the dura matter in the brain. So the eyeballs are truly an extension of the brain, because the sheath that comes around the optic nerve becomes the sclera, The sclera then becomes the cornea. It's the same type of collagen, just arranged in different ways to give it the white color, the clarity of the cornea, and the material that fills the sheath. So that's how you should think of the outermost layer. Now, when we talk about the second layer of the eye, that's when we have something called the uvea. I'm going to draw it for you now. Okay, so here, this is what we call the uvea. Now, the uvea is a funny word. I think it means grape or grape skin. Someone in Latin thought that would be a good idea because that's apparently what it looks like when you dissect through the eye. And it's true, it kind of looks like a shriveled grape. But the uvea is the second tract in the eye. And it comprises of a few key structures, okay? So there is the iris, which is this line over here. Then we have the ciliary body, which is this bulbous thing over here. And then we have the choroid in the back, okay? So this is very important to understand because the word uvea, you may recognize from the word uveitis. So when you think of uveitis, you should try and think in your mind, okay, we're talking about inflammation of the uvea. So probably one of these structures is going to be inflamed. So that is why we need to think about the eyeball in layers. And the third layer is an important layer, of course, that is the retina, the neurosensory retina. And this retina is the thing that becomes contiguous with the optic nerve and transmits lights that we see in the external world into the brain. So it is the retina that has the axons that send off into the brain. Now, of course, there are other structures in the eye. Of course, you know, we all, one of our favorite structures, of course, is the lens, which is kind of this crystalline structure that's suspended in the middle of the eye with the zonules connected to the ciliary body. And of course, there are different areas inside the eye which have different names as well. But for this first part, I just want you to think about the outer layer of the eye being comprised of the black, the red, and the blue. So just keep this in mind as you go forward. And in this lecture and for your clinics, it's very important to think of the eye in this way. So when we talk about our first diagnosis of iritis, okay, let's look at this picture together. You see this picture of an eye that's in your clinic. You're immediately drawn to this very red erythematous eye, and you see that a lot of the inflammation is kind of actually near the area called the limbus. The limbus is the area where the sclera and the cornea meet. And you see that this area of injection is much greater than kind of the areas elsewhere in the eye. Now, if you look very carefully at this picture, you also see that the pupil is not completely round. So instead of being a nice circle, you see that there actually is kind of this weird D shape to it. It looks like this area is not completely circular. So, this is kind of how we should be thinking about this diagnosis of iritis. Now, of course, again, I'm not going to go over the nitty gritty of all the signs and symptoms and all that, but for conceptually, I want you to think about iritis in this way. So what is iritis? So when we talk about uveitis, there are different classifications for uveitis, okay? Now, the first one is anterior uveitis or iritis. Those two terms are pretty synonymous. So if you see anterior uveitis and you see iritis, we probably mean the same thing. We also have intermediate uveitis, and we have posterior. I'm going to focus only on anterior uveitis for this case because it's the most common. About 70% to 80% of all uveitis you see will be exclusively anterior uveitis. So it's good to know that this is the most important type of uveitis. Now, when we think about anterior uveitis, the iris is the most likely structure to be inflamed, but the ciliary body can also be inflamed as well. But usually it's the iris that's the most inflamed structure. And when we think about this, this kind of explains why we have this type of inflammation that's kind of this limbal injection, because the limbus is home, or behind the limbus, there is another structure there. And if you actually look back at our picture, you realize that here is the limbus over here. So that's where the sclera meets the cornea. And if all this inflammation, all this injection of vessels, if you imagine in 3 dimensions, the sclera above here, like in the previous picture, right underneath that is actually the ciliary body. And we know that the ciliary body is very closely connected to the iris, which is the main site of inflammation for anterior uveitis. So that's why having a good sense of the anatomy explains a lot of the signs and symptoms that we ask for our patients to get a sense of what their diagnosis is. Every question that we ask, every sign that we see on the examination has an explanation. There is a reason why different structures have different problems. So that's why it's important to understand this for iritis. Now we're going to move on now to the cornea. So switching gears completely, the cornea I drew before as one black line, right? But actually there are 5 layers of the cornea. You know, we have the epithelium over here. That's kind of like the epithelium of our skin. We have Bowman's layer, which is kind of a pseudo basement membrane. You remember from pathology. We have the stroma, which is 90% of the cornea. That's responsible for having transparency. We have descemes, which is another basement membrane. And then we have the endothelium, which is on the inside of the eye, right? So this is where the inside is. This is where the outside is. And the endothelium is very important for making sure that the cornea stays dry. This has those sodium, potassium, ATPase pumps. You remember from your undergraduate training that, you know, helps with making sure that the sodium moves in the right direction and that then water follows accordingly to maintain this perfect 76% detergescence of the cornea to maintain that clarity. Now, sometimes as a medical student, I was very confused. How am I going to remember all these layers? Why do I even care that there's 5 layers of the cornea? Well, you know, let me get into that. So first, you'll notice that I again drew this in a pathology slide. To remember corneal anatomy, it's very easy. You just have to remember the A, B, C, D, and E. So if you can remember these 5 letters, you'll remember the layers of the cornea. So going from outside to in, A is for epithelium, okay? So just say it, epithelium, okay? I know it's an E, okay? But say epithelium, and that is the outermost layer. B is for Bowman's, C is for C stroma, like say it together, stroma. So that's how I think about it. D is for decimate, and E is for the endothelium, okay? Epithelium, Bowman's, C stroma, decimate, endothelium. You won't forget it now, okay? Because guarantee you, someone will ask you at some point in your life about the 5 layers of the cornea. There is also this like 6th layer that nobody like really talks about, but is obviously much above your level. So don't worry about the 6th layer if you may have heard of it or not. Now, why do we care again? I'm going to explain a corneal abrasion, which is like the most common diagnosis that you'll make as a family medicine emerge, medical student in the resident clinic, whatever. It's a corneal abrasion, but we look for things for corneal abrasions, but do we really understand what's going on in the anatomy? So when someone has a corneal abrasion, okay, they get like a tree branch that hits their eye, what happens? So this again is the 5 layers of the eye. Remember, we have the epithelium, Bowman's, stroma, decimes, endothelium. Now, what happens when you get a corneal abrasion is that this area, let's say this area over here, this entire area will get scratched off, okay, because the branch kind of rips that stuff off. It's kind of like when you fall and you skin your arm. It's the same idea, right? The skinning is kind of the surface layers of your skin, similar to corneal abrasion. It's going to be the surface layers of the cornea. And then you see in this picture here that someone has applied fluorescein staining to this eye. And how does fluorescein staining work? Well, fluorescein only stains kind of devitalized corneal cells. So there's many stains, there's rose bengal, fluorescein. They basically stain areas of missing epithelium. So if the stroma is exposed, which in this case it is, then when someone applies fluorescein, you'll see that this area of stroma is going to light up. Whereas in these areas here, where there is intact epithelium, there is no fluorescence of the cornea. So that's why corneal abrasions light up, because this area of the corneal epithelium and even the Bowman's is missing. Now, of course, thankfully, we have limbal stem cells that regenerates like our skin. And these cells eventually, after a few days or so, will start to fill in this area over here. So then you see that over time, the eye magically regenerates itself over here. The cells come back, they secrete their own basement membrane, and then eventually they slough off, and then they regenerate the area. And then when you look back into someone's cornea, you'll never be able to tell that someone has evidence of a corneal abrasion. Kind of like on your skin. If you fall, you scratch yourself, probably in a few weeks, you'll not even know that you had this damage. Now, obviously, if you had a really big accident and you had a much deeper injury, that will leave a scar. And that can happen in corneas too, but it's not common for that to happen, okay? So that's hopefully a good understanding of corneal abrasion, very common diagnosis. Now I'm going to move next to the angle. Now the angle is something that's always talked about in ophthalmology. And I want you to think, whenever you hear the word angle, that means that someone's talking to you about glaucoma, okay? someone that is kind of what diagnosis that people are trying to get you to think about when they're asking you about the angle. Now, what is this angle that people talk about in the eye? Like, I remember, like, if you look at this picture here, there are like so many different angles that could, possibly be talked about. Is this the angle? Is that the angle? This the angle? Like, which angle are we talking about when we're talking about the angle anatomy inside the eye? Well, it's very simple. It's this angle over here. Okay, this angle over here. It's the cornea iris angle. So I'm going to show you this right here. Okay, right there. Okay, this is the angle that we talk about. So this is, it's the iris, so irido. This is the cornea, so corneal angle. Okay, but honestly, it's a very big mouthful. So we just say angle, okay? And we all assume that we know what we're talking about, okay? So next time you want to sound smart, just say angle. Don't say iridocorneal angle. We all know it's the iridocorneal angle, but it's too much to say. So just say angle. Now, why do we care about the angle, okay? And what is glaucoma even? Now, again, this is not my lecture, so I won't spoil the fun of glaucoma for you. But essentially, glaucoma is a problem of the optic nerve inside your eye. And the nerve gets damaged for some reason, okay? The nerve gets damaged, and period. And it's associated with increasing pressure in the eyes, not caused by increasing pressure in the eyes, but there is an association, and it is the only modifiable risk factor for glaucoma. So why am I talking about increased pressure, right? Because I thought increased pressure was not what glaucoma is, which is true. Glaucoma is not about an increase in pressure, but it's the only modifiable risk factor. And when we talk about intraocular pressure, we talk about the angle, because intraocular pressure is caused by fluid being produced in the eye. Where is this fluid being produced? It's being produced by the ciliary body, okay? This is a ciliary body over here. You remember that red structure, part of the uvea, iris, ciliary body, choroid. This structure produces the aqueous. The aqueous then goes around the pupil here, and then eventually makes its way to drain in the angle to the trabecular meshwork and associated structures. So that's why we care about the angle. We care about the angle because that's where fluid in the eye drains. If fluid is not draining properly, the pressure in the eye goes up. This does not mean the patient has glaucoma, but this means that certainly this patient, if they had glaucoma, would get much worse from pressure. It's very confusing. Glaucoma, people think it's very easy. It's a very complicated disease. People don't even know what causes glaucoma yet. Can you imagine that? There's an entire subspecialty in ophthalmology called glaucoma, where people don't even understand what causes glaucoma. So very complicated, but for you, just think about this angle where fluid that's made in the ciliary body, this aqueous, drains through, and it is responsible for causing increases in pressure, which can make glaucoma worse and is the only modifiable risk factor. Okay. Now, when we talk about the angle, we can talk about open angle or we can talk about closed angle. Now, the one on the left is going to be the open angle, and the one on the right is a closed angle. Let's focus on the open angle. So you see the ciliary body is making this fluid. It's coming up past the iris and lens through the pupil, drained very nicely. Now on the right, if someone has a closed angle, what happens is that their fluid is being produced in the ciliary body. As it tries to exit into the anterior chamber, this pupil, this iris, is actually stuck down to the lens because the lens is very big, or for whatever reason is pushing up here, and it's causing apposition, meaning that the lens and the iris are stuck together, and now the fluid, the ciliary, the aqueous humor cannot go through, cannot pass this area of blockage, and thus the pressure then gets pushed upwards, and as a result, no fluid is able to drain through this angle. It's like a vicious cycle where the lens goes up, the angle closes, and then as a result of the angle closing, the pressure gets even higher, and then things keep moving up. It's a very vicious cycle, and that's why we talk about acute angle closure glaucoma is the one on the right. The one on the left is open angle glaucoma. Now, if we look at a patient in the clinic who comes to us, again, we see that there's two different patients, not the same patient, different patients. On the left, again, we see that this patient has open angle glaucoma, and the one on the right is closed angle glaucoma. How do I know it's open and closed? Well, we use the slit beam. Okay, that's why we have a slit lamp. The slit lamp is an amazing structure, instrument that allows us to do so much and figure out so many things that are going on with the eye. And if you see here, this open angle, you see that it actually looks a lot like the angle, the iridocorneal angle. And you see how it's very open. But if you look at this angle over here, this iridocorneal angle, you see that it's so tight. You see that? That is why we mean open angle versus closed angle. I mean, in this picture too, you can see that the cornea looks a bit it looks a bit edematous. There's all this kind of reflections that you usually wouldn't see. The eye is more red and injected. Certainly looks less happy than the patient on the left who's just chilling, okay? Again, when you think of glaucoma, similar to how you think about hypertension in a patient, your family medicine clinics, a patient who has glaucoma, when someone says glaucoma to you, your instinct is to think about acute angle closure glaucoma, which is this bad thing on the right. But in actuality, you should be thinking about this patient on the left. Similar to how when you think of patients with hypertension in clinic, most of those patients are like little old ladies, their like blood pressure is like 145 over whatever, 95. You start them on like a diuretic, you check them back later, you ask them, how are you feeling, Mrs. Jones? Miss Jones says, I don't feel anything at all. You're like, that's right, because you just have very mild hypertension, not a big deal. Same thing with glaucoma. Most people don't know they have glaucoma, or if they do, they're going to be asymptomatic from it. But it's very rare for someone to present in malignant hypertension, hypertensive crisis, so like emergent hypertension where their blood pressure is like 220 over 120. It's also very rare for someone to present in acute angle closure glaucoma. Okay, so this is how thinking about the anatomy can be very helpful. So I hope that was useful to you. Finally, I'm going to jump into the last most common diagnosis, and that's going to be somewhere in the posterior segment. So we spent a lot of time talking about the anterior and posterior segments, and what I want to come across to you and make you understand is that the eye is compartmentalized into different parts. We have the anterior segment and the posterior segment, which is different from the anterior chamber and posterior chamber. Okay, so I want you to think about this and listen carefully to the words that I'm saying. So when we talk about the anterior segment, that's this part over here. So you may hear of, for example, in Toronto, Dr. Ike Ahmed is the fellowship director of the Glaucoma and Advanced Anterior Segment Surgery, or the GAS fellowship. Okay, so this is the anterior segment, meaning that they operate mainly in the anterior segment. The back part of this is the posterior segment, okay, which is basically anything behind the lens. Finally, when you look at anterior segment, this is comprised of two parts. There is the anterior chamber and the posterior chamber. Very important, because this, I know it seems very, redundant or not useful or important information. And it might not be if you're going to be a family doctor, but if you're going to be an ophthalmologist, these words really matter. Okay. So I want to just impart on you this. So let me simplify this for you again, because I love simplifying things. And I want you to take a look at this picture here. Okay. So I am going to show you here. So look at this. This area in front of the iris, underneath the cornea, is the anterior chamber. So in front of the iris, under and behind the cornea, anterior chamber. Now, the posterior chamber is behind the iris, in front of the lens. Behind the iris, in front of the lens, posterior chamber. That's why when you see the acronym PCIOL, that means it's a posterior chamber intraocular lens, which means that the lens is somewhere in this area, usually in the bag. Okay, so that's posterior chamber. Remember that these two things together comprised of the anterior segment. And then when we look in the back over here, this area is the vitreous chamber or the posterior segment. They're synonymous. Okay, so posterior segment, vitreous chamber is the same thing. Okay, so take a look at that. Take a mental snapshot of this, because the words you say matter, and you want to be accurate when you're describing things in ophthalmology. Like the eye is very small already, so you want to be very specific as to what you're talking about, where things are, in the eye, okay? How do we apply this? Well, we can have a posterior vitreous detachment. Look at this picture here. This is a picture of you're looking at the slit lamp through a 90 diopter lens, or maybe smaller, let's say like a 78 diopter lens. And you are focusing now into the vitreous, so the vitreous chamber or the posterior segment, and you are looking at this little ring over here. That's what you're looking at, okay? And then you see the optic nerve defocus behind that because you're focused right now on the area of the vitreous. So what are we talking about here? What are we looking at? Let me explain. This is the posterior chamber. Sorry, segment. See, you can make a mistake very easily. Posterior segments, or we're in the vitreous cavity, vitreous chamber, all synonymous. When you're young, you're born with this vitreous that is very firmly adherent to the retina. Okay, so remember that we have the retina inside of our eyes that goes to the optic nerve. We also have the choroid underneath of it that supplies the blood to it. And then on top of that, we have the vitreous, which is in the posterior segment. Okay, usually this vitreous is very firmly adherent to the structures in the retina. Now, when we get older, this happens to everybody, but usually around the age of 50 or 60, the vitreous becomes detached, hence vitreous detachment. And this vitreous becoming detached usually starts locally. So I want you to look here. It usually starts in an area, let's say it starts over here, okay? So this area of the vitreous is detaching. And then this area will become detached, and then this area. And then eventually the whole vitreous will kind of go into the center of the eye. And let me redraw that for you now. And when that happens, basically you get the vitreous detachment. So it looks kind of like this. When everything's all done, it's kind of like this, and all the vitreous is kind of syneretic. It becomes liquefied, and it's no longer attached to the retina. Now, you may know that people who have PVDs often come in with flashes and floaters. That's the most common symptoms that these people have. Why do they have floaters? Well, you can look at this picture and you can see that all this syneretic material here is floating around, and then it's going to cast shadows on the retina. That's why they see floaters. And you may be wondering, well, why do they get flashes? Well, remember, when the vitreous was pulling off of the retina, every tug of the vitreous on the retina will send a flash of light to your brain, because your brain thinks the retina is being stimulated, but it is mechanically, but your eye cannot differentiate between mechanical stimulation and a photon of light hitting it. So your brain thinks, oh my God, there's a flash somewhere, but in actuality, it's just a vitreous detaching. As the vitreous eventually detaches, the symptoms of flashes will stop. Now, sometimes the vitreous detaching, which is a normal process, can cause a pathological process where the retina can become torn or detached. And how does that look like? Well, let me show you. This area where the vitreous was detaching, if it pulls too hard, what can happen is then the retina can have a tear. And this is called a retinal tear, okay? This process here is a retinal tear. And that is why you send these patients to ophthalmology, or why they're sent to us, so that we may examine the retina and ensure that there's no tears. Because if a tear is left untreated, what can happen is that now this syneretic fluidic vitreous can seep behind this tear. And what can happen when that happens? Then the entire retina can become detached. So you see here, the retina can now become detached. And that is called a retinal detachment. Now, does every patient with a PVD get a tear or detachment? No, okay? 90% of patients who say, doctor, I have flashes and floaters, are going to be completely fine. No tears, no detachments. Approximately 1 in 10 patients who have flashes and floaters will have a tear. And of those patients, probably 1 in 100 tears that are left untreated long enough will go on to detach. Okay, so the point of this picture is to get you to conceptually understand what's going on. Now, you may be wondering, what is that ring that I saw in this picture that you showed us in the beginning? Well, that ring is called a Weiss ring, named after probably someone named Weiss. And this Weiss ring is the same ring as you see here in this picture. So this ring and this ring are the same. And that's basically where the vitreous was very firmly attached to the optic nerve. And as that vitreous detached from the optic nerve, it's going to be in a ring, obviously. And that's the Weiss ring that you see. So if you see someone with a Weiss ring, you know that the vitreous has detached, because the Weiss ring, or the area of vitreous around the optic nerve, is typically the last thing to become detached from the retina. So if once that has come off, you can be certain that the rest of the vitreous has already detached. Okay, so if you see that in clinic, you know that this patient is having or has had already a PVD. Okay, so that's a conceptual way to understand what's going on for the 4 most common diagnoses in the clinic. Okay, so we talked about iritis. I talked about anterior uveitis being the most common. We went through the corneal anatomy, looking at the 5 layers of the cornea and understanding how that can cause abrasions, or why abrasions, like how that clinically and anatomically looks. We briefly touched on glaucoma and the angle, now that you understand what the angle is. And you understand now too, the most common diagnosis we see in the eye clinic, which is to look at posterior vitreous detachments. All right. So we're gonna go see some patients next. But before we do, I think we're gonna do some Kahoot first and see if you guys have been paying attention. Okay, so we are going to move on now to my Kahoot.
Michael, do you have time to take some questions now?
Oh yeah, sure, let's do it.
All right, so I got one question here. Do PVDs cause a change in visual acuity?
Nope, they should never cause a change in visual acuity unless they have also, no, I'm just gonna leave it at that. No, they do not cause a change in visual acuity, period.
All right. And that's it for now.
Perfect. So we're gonna move on to Kahoot.
Wait, Michael, I think Kieran had her hand up.
Yeah. How quickly do PVDs need to be seen?
Great question. I will get to that in my second hour talk. But generally, if flashes and floaters should be seen approximately within 72 hours, unless they have other high risk features, which I will talk about in my second hour. So while we're answering more questions, I'm going to set up our Kahoot. So you guys all have probably done this before, but if not, just go to this website, kahoot.it on your phone, or you can take your phone and just scan this QR code and it'll take you to the web page. Put in your game pin here, this number here, and then put in a nickname, not your real name, please, in the Kahoot to keep it fun and anonymous. Feel free to show how clever and witty you are with eyeball names. iDentist, good one. IKEA, I feel like I remember that from last year. Very good. So remember, the top 10 people will be entered into a draw to win 2 $25 gift cards. My questions are not very challenging. So you remember, you also get points for answering quickly as well. So you get points for correct answers, first of all. And then secondly, it's going to be based on how fast you answer the questions. Okay, I think there are 10 questions, or 8 to 10 questions I have, and they're completely mostly based on what I talked about, some extra stuff as well. So I'll give it another 1 minute for people to scan this QR code. UI Popions we saw, that's good. Momo. All right, glaucoma fleck, globular. People still coming on, which is great. Good to see some participation. I know Zoom teaching is not the most fun. I wish we were in person, with a whiteboard and we can be making it more dynamic, but I think Kahoot is not bad. Also, $25 gift card is also pretty good for participating. So we're gonna start. The first question, so the question should come up on your phone, the choices, I believe. And the first question I had is going to be, which part of the eye is inflamed in anterior uveitis? The most the most predominant site? People are pretty quick. That's good. Remember, we talked about this. This is the red structure. Remember, there's 3 parts of the structure. There is the iris, the ciliary body, and the choroid. And we see that the answer is indeed iris. That's great. Ciliary body can be inflamed in anterior uveitis, certainly, but I would say that the most common area is going to be the iris, and ciliary body is second. Okay, so that's great. People are very quick. Like I said, my questions are not very challenging. Try to keep it nice and easy for you guys. Which layer of the cornea is responsible for controlling hydration levels? So remember, there's 5 layers, the A, B, C, D, E. We have the epithelium, Bowman's layer, C stroma, the Descemet's membrane, and the endothelium. And one of these layers is responsible with the nice sodium, potassium, ATPase pumps that help to pump out the sodium and help water follow along with it. And of course, that is going to be the endothelium. Yep, so that's good that most people got it. Remember, Bowman's layer is just a basement membrane of the epithelium, which is on the top, the frontmost part of the cornea. We have some moving people around. Got a future ophtha, very good. Third, what structure in the eye produces aqueous humor? Is it the cornea, the iris, the ciliary body, or the lens? Remember, the aqueous is the fluid that is produced in the front of the eye. It's nourishing, it has nutrients, it helps recycle waste products and drains into the all-important angle of the eye that we think about in glaucoma. And that structure is the ciliary body, of course, and everyone obviously aced that. Excellent. You guys are all doing great. I got it. Great job. Next question. What is the preferred treatment for anterior uveitis? Now, I didn't talk about this. Is it topical steroid drops? Is it oral NSAIDs? Is it oral steroids or topical antibiotic drops? So you may not know this, and that's okay, but just there are probably things you can rule out. You know, usually inflammation. Is it an infection? Probably not, but let's see what people said. Yeah, topical steroid drops is the dominant answer. Of course, the treatment regimen, all stuff you learn in residency about what exactly to do, what the exact perfect concoction is. But in general, topical steroid drops are by far and large the treatment of choice for anterior uveitis. I will take some questions at the end of this session, okay? So if you have any questions, feel free to keep it for the end of this session. Next, what is the most common symptom in open angle glaucoma? Pain, blurry vision, photophobia, or asymptomatic? So remember, this is for open angle glaucoma, which is different from, of course, closed angle glaucoma. And we spend a lot of time talking about this, comparing it to hypertension or little old ladies who don't feel anything. And the answer is asymptomatic. Very good. Excellent. These are the most important points. I'm trying to hit on the most important things, okay? I don't like to test minutia because it's not really useful. If a patient had a Weiss ring, where would you look for it in the eye? Is it the cornea, the lens, the vitreous, or the optic nerve? Maybe slightly trickier, but I think I had a pretty good explanation, I hope. Nice. A little split there. That's good. So I see that slightly more than half the people got the correct answer, which is vitreous. Now, I do see why people click optic nerve. Usually, when the vitreous is attached to the optic nerve, you will not be able to see it because vitreous is transparent and it's firmly attached to the optic nerve. Once it detaches in a PVD, then it's called a Weiss ring, and you will see it in the vitreous. So yes, it's a ring because it's where it used to be attached to the optic nerve, but you would not look for it at the optic nerve. Remember, the picture I showed had the optic nerve and the retina defocused, and you were actually focused in the vitreous to look for the Weiss ring. Okay, so this is a good trick. It's actually a skill that I ask medical students to do when to test if they can actually use their 90 diopter with the fine focusing required for the slit lamp, because if you are able to find the Weiss ring, that tells me that you're able to have control of your lens, to be able, your 90 diopter lens, to be able to look at the posterior segment, and then you have enough control to be able to focus into the vitreous to be able to see the Weiss ring. So that's a good tip for you, is that if you want to work towards something, being a medical student and being able to see Weiss rings is very impressive. So I definitely would encourage you to all to try and get to that level at some point in medical school before you start residency. A lot of movement, I like it. That's great. I got it. Number one. Second last question here. Where is the posterior chamber of the eye? This one is a bit more tricky. Remember, we have the anterior chamber, the posterior chamber, the anterior segment, and the posterior segment. These are all different things. So read carefully and figure out where this posterior chamber is. This one is not easy. Trickier one. Between the iris and the lens. So we see that most people still got it, which is very, very good. Remember, the anterior chamber is between the cornea and the iris. The posterior chamber is between the iris and the lens. Anterior segment is the anterior chamber and posterior chamber together. And the posterior segment is kind of everything behind the lens. Okay, that's excellent. I got it, still number one, fantastic. And the last question, what is the preferred treatment for corneal abrasion? I also didn't go into this. So let's see if anyone here knows, do we use oral antibiotics, topical, and tetracaine drops, or just observe closely? This one could be a little bit of a toss away, depending on what site, where you practice. But in general, I would say that most people would actually say topical antibiotics are still used. So I know that it makes sense to just do close observation. And can you get away with close observation? Yes, absolutely. You probably could get away with it. However, most centers would still like to treat with topical antibiotics because of its prophylactic nature. Okay, we don't want this corneal abrasion to become a corneal ulcer, because a corneal ulcer is very bad because you can go blind from this. So we don't want to let something that was a simple tree branch to the eye lead to something that can cause you to go blind. Now, when you have an abrasion on your arm, are you going to put antibiotics on it? Probably not. You might put some polysporin, you might not. But when your arm gets a little bit of cellulitis, that's probably not as big of a deal as if your eye developed an ulcer from this tree branch with vegetative matter on it, causing an abrasion on your eye. So most centers and most ophthalmologists and emergency doctors will give a week's worth of topical antibiotics to prevent any infections. Okay, so that is why this was the correct answer. See, so our podium today, again, this is not necessarily the gift card winners, but Oculus is number 3, Anonymous number 2, and number 1 is, I think is it I got it? Is it I got it? It's I got it. Very good. So if you're in the top 10, or just take a screenshot of your phone, and just so that you can prove to us later if you're the prize winner. Okay, that was awesome. So I'm gonna stop here and then move on to my next presentation. But if anyone has questions in the meantime, I'm happy to entertain any.
Okay, so you have 2 questions in the chat. The first one being is, can you repeat about why patients feel flashes and floaters on PVDs?
Yes. So flashes are caused by the vitreous pulling on the retina as it detaches. Okay, so let me go back to my picture that I had here. So every time the vitreous pulls away from the retina, that pulling causes a flash of light that the brain interprets as a flash, because the retina doesn't know the difference between a photon of light hitting it or some jelly physically tugging on the retina. And that's why you have a flash. The floaters are caused by the condensation of the syneretic vitreous once it detaches from the retina, clumps up into little balls that float around your eye, and then those balls cast shadows onto your retina, and that's why you see them as black floaters instead of just being, transparent, which they are, but they cast shadows.
Great. And the other question is, why do the superior and inferior aspects of the eye also stain green with fluorescein dye? in the corneal abrasion slide, you had a picture of one and you could see there was uptake along the eyelids as well.
Yeah, so this is not uptake. This is just, it's just pooling there because, you know, when you put in a crap ton of fluorescein in the eye, it's going to naturally pool. This is where your tear lake sits. You know, like we have tears that constantly bathe our eyes. And this area is just areas of pooling with excessive fluorescein. So you may see this, but this is not true staining because if I got a Q-tip and I wiped away all of this, it's going to be gone. But if I took a Q-tip and tried to wipe away this, it will stay stained. So this is why this is called staining, and this is not staining. This is just like excessive fluorescein. Okay. All right. So as promised, the second part of our talk today is going to be talking about how to interpret this hieroglyphics. Okay. This is a note that I would write. So like I physically wrote this as a fake patient, but this is a very close example of a note that I would write, and most ophthalmology people would write something very similar to this note. Okay, so feel free to take a screenshot or whatever it is that you want to do to it, because this is how your notes should look like. And I'm going to highlight a few things. The first is that this looks very complicated. Okay, and you may be very overwhelmed by all the acronyms and letters and drawings. It looks like nothing like any other note in medicine at all. Okay, but like I said, everything can be simplified to the bare basic concepts. Okay, so I'm going to show you how I think about these ophthalmology consult notes, similar to how I think about every single diagnosis in ophthalmology. I break them all down to their simplest components. I can also break down this ophthalmology consult note for you too. So this is how I think about it and how you should think about it as well. So I color coded it for you so you can understand what the different areas mean. So the first area is the green area, and this green area is actually the simple history. So this is the area where you, as a medical student, are probably the most helpful because you can actually do all this because it's similar to what you do for the rest of medicine. You notice that as part of the big six that we usually ask for, we also add a past ocular history. Why do we ask about a past ocular history? Because we're in ophthalmology. So we care about their past eye health separate to their past medical health. So we distinguish the difference between these two things. When we ask about past ocular history, you always want to ask about any surgeries they've had, any laser procedures they've had, or if they wear any contact lenses, because these three will have an impact on what my impression and plan is going to be and what my differential is going to be as well. The rest is as usual. I write mine on the right side of my page. That's just how I like to do it. And then I then also have an area that is for my HBI. You notice that my HBI is very simple because, again, you know, ophthalmology is certainly about efficiency and wanting to have the hit every single important point. So I learned that my 64-year-old female is coming from the emergency room, and she's referred to me for flashes and floaters in her left eye. She says that she's had 3 days of floaters in the left eye, which are described as spider webs. And this is very common for patients to describe their floaters to you and all sorts of funny things. They'll say, I see spider webs, I see this long branch, I think I see flies in my eyes. Those are like various common things. The most important thing to realize is that none of that matters. Whatever they tell you, I just write down floaters. You know, I sometimes write down the word spider webs in quotations, meaning the patient says that, so that next time I see the patient, I say, oh, how are your spider webs, Mrs. Jones? And they'd be like, oh, my spider webs are so much better, doctor. Thank you for remembering. But does it actually matter medically? No, it does not matter what they see at all. As long as they say it's black things floating in my eye, it's a floater. It does not have any prognostication factors. Flashes of lights, I, again, do not need to describe them. It's enough to say that there are flashes of lights. Important question to ask for every patient with flashes and floaters is, do they have a visual field defect? Because if they have a visual field defect, then you might be worried that this might be the patient that's, you know, 1 in 1,000, 1 in 10,000 that has a retinal detachment. Other high risk factors for flashes and floaters is history of trauma, of course, history of high myopia, meaning that their prescription glasses is stronger than, let's say, -9 diopters, and they do not have a family history of a retinal tear or retinal detachment. So these are the 6 questions I ask every patient who comes with flashes and floaters. Do you have any flashes? Do you have any floaters? Do you have any visual field defects? Did you have a trauma? Did you have are you a high myope? Do you have a family history of a tear or detachment? So every patient should have these 6 questions asked on top of your usual big 6. So that's the history. That's the easy part, okay? Now, the examination is where the trickier part comes in. In purple, this is VPET, okay? This is the vital signs in ophthalmology. Like how other specialties have, sorry, not other, like how medicine has, the vital signs of heart rate and blood pressure and respiratory rate and all that good stuff. We have other vital signs. And these vital signs should be checked at every single visit because they are essential to understanding the whole examination. If you were a family medicine or non-ophthalmology person and you're seeing patients, I honestly could not care about any of this part in blue. I do not care. I don't even care about your impression and your plan, really. I just want the green part and the purple part, because having a very good history and these vital signs, not even the pressure, honestly, if you're in a family clinic, I just need the vision and the pupils. That will be able to tell me enough about this patient and to triage them appropriately. So it is essential that every patient gets a vision checked. When we check vision, we usually write SC or CC, depending on if they were with or without glasses. SC means without glasses. CC means with glasses. The C means correction. The S means sans. When we write someone's visual acuity, usually we write them in things in 2 ways. We either write things one on top of each other, and if we do that, that means that the one on top is the right eye, and the one on the bottom is the left eye by convention. Okay, so if you see 2 things that are on top of each other, one is going to be the right eye, one is the left eye. We say that there is the pupils. I write here ERL, equal and reactive to light. Notice I don't put an A, because if you say perla and you don't even know what that means, then there's no point, because I don't even check accommodation pupil responses. So you should probably not be doing that either. I write that there's no RAPD, which is very important to understand. I write that the extraocular motility, EOM, is full. OU is an acronym meaning both eyes. And then I write my T here. T stands for tonometry. And I checked it with a tonal pen. So I write down how I checked it. And then I write that there is one on the left and one on the right. And this is to represent the patient's right and left eye respectively. So everything in a note is as if you're looking at the patient. So if I'm looking at the patient, this 14 is where their right eye is, and this 16 is where their left eye is. So 14 is for the right eye, 16 is for the left eye. This is the vital signs of the eye. Very important that you do this for every patient. Now you're getting into the actual examination of the patient, which is in blue. The anterior part of the eye is this part here. You can call this the anterior segment. And then the posterior segment is the bottom part here. Let's interpret the hieroglyphics, okay? So down the middle, this column is basically all the structures that I'm looking at. And on the sides are my descriptions of each respective side. So EXD, stands for external. So this is things like on their face, like do they have a big hemangioma somewhere? Like do they have like rashes somewhere in their face? That's external. LLL, lids, lashes, and lacrimal system. So I'm looking at their eyelashes, and here I write that this patient has blepharitis, which is inflammation of the meibomian glands and eyelashes. SC stands for sclera/conjunctiva. So now I'm seeing if are the vessels, is it white, which it normally should be, or is there some injection? Is there some type of injection on the blood vessels? The K stands for cornea. Don't ask me why it's a K. It is clear in this patient. AC stands for anterior chamber, which here I write D plus Q, which is deep and quiet. I is for the iris. I wrote a line here meaning that, I either didn't look at it or I didn't think it was remarkable. It's not a pertinent positive or negative, I should say, because if you're looking at the anterior chamber, you should always write deep and quiet, because it is a pertinent negative that it is deep and quiet. The lens is L. I write here 1 plus NS, which means 1 plus nuclear sclerosis, which is a type of cataract that you can have in the lens, which makes sense because this patient is 64. So I should expect them to have at least some amount of cataracts. VIT is for vitreous. And here I write that they are Schaefer negative. Schaefer is a sign that we look for in ophthalmology, showing how someone is, how likely they are to have a retinal tear. Again, a bit beyond the scope of my talk. And then when we look at the back of the eye, you notice that this circle is the looking at the fundus. The optic nerve is this circle here. These lines coming off of it are the vessels that come out of the optic nerve. So that means that this area here in the center is the macula, and around here is the surrounding retina. And I draw these lines here, which is, at least in Toronto, our convention for saying that we use scleral depression to look at the periphery of the retina. And I noticed here that I write DMVP, which is disc, macula, vessels, and periphery. And I noticed that the disc cup to disc ratio is 0.3. The M, I put a check mark, looks good. The vitreous, the vessels look good. And in the periphery, I write that there's no retinal tear, no retinal detachment in both eyes. I notice that this patient in the left eye has a Weiss ring, and I draw it in here and I label it as Weiss ring. So now putting that all together, we have a 64-year-old patient who has flashes and floaters without visual field defect, without high risk features. I see a Weiss ring in the left eye. So I'm fairly confident that this patient has a PVD in their left eye. I did not see a tear or detachment on 360 degrees of a scleral depressed examination, which is when you look very closely at the periphery. And then my plan is to follow up in 6 weeks. And I told them to return to clinic as soon as possible if they're having increased flashes, floaters, or field defect. Okay, so this is a very common example of a note in ophthalmology. So yeah, like I try to make it as basic as possible, but this is what you will see when you try and read our notes. So it's good to be able to start understanding some of the terminology and the layout of the notes and how to think about and structure your consult notes. Okay, I'll take any questions now before our break.
So first question we have is, could you explain why high myopia is important to ask for someone with flashes and floaters?
Sure. High myopia means that your eyeball is typically longer than a normal person's eye. So if you're nearsighted, then your eyeball is typically a bit longer, especially if you're a high myope. And if your eye is longer, then the retina wallpaper of the eye can become stretched and thinned. Things that are usually thinned and stretched are more prone to tearing. So that's why we ask for high myopia, because your eyeball is longer, your retina is more prone to tearing, that will increase my pre-test probability that there is something that I'm worried about when looking at the eye to check for any retinal tears or detachments.
Next question is, what are signs you look for to do a scleral depression versus just indirect VISCO?
So when someone has flashes and floaters, you have to do a scleral depressed examination, because most times any retinal tears you see will happen in the periphery. No one has a retinal tear next to their optic nerve. It's going to be in the periphery of the eye. So if you cannot look in the periphery, you cannot be confident in your diagnosis. So that's why optometrists, for example, do not have this ability. Even on Optos wide field imaging, you cannot get as far out to the ora serrata as you want to, and therefore they can miss tears in the periphery, which is why they get sent to us for examination. So the answer is always for anyone with flashes and floaters. But generally speaking, it's based on the clinical situation. But in someone with flashes and floaters, you have to do a scleral depressed examination or use a 3-mirror lens if that's what your institution does.
Next question, how do you feel about ultrasound for retinal and vitreous detachment?
Yeah, I mean, as an emerge doc, I would say that, or, family medicine +1, whatever, POCUS is getting very sexy, but I will say that it is, it's very specific, using POCUS to diagnose a retinal detachment. Because if you see a retinal detachment on your POCUS, most likely, and you actually know what you're doing, then there most likely will be a retinal detachment when we see it. But just because you didn't see one doesn't mean anything. So it's a very low sensitivity for diagnosing retinal detachment. My personal thinking is that if you're in an academic center, you should just refer to ophthalmology and save the patient 30 minutes of their time, or in your time too, because it does not, influence my decision in any way whatsoever. So I personally don't think it's useful for ophthalmology. It's especially not useful for children. Like, you should not be doing POCUS on kids, because if you do it on a little child and then you make them very upset and then you send them to me afterwards to check for papilledema, for example, and then I'm trying to examine this screaming 2-year-old that you like shoved a probe in their eye, they're not going to open their eyes for me. And then that would have just wasted everyone's time. So I really discourage the use of POCUS for kids for ophthalmology. For adults, I think it's not really that helpful. So feel free to do it if you want, but I don't think overall it's going to be that useful.
No more questions here.
Okay, perfect. So maybe we'll take a 5-minute break. So we'll finish. We'll come back at 4:12 Eastern time. My next hour is going to be a very packed hour. I have 15 different, the most common cases in ophthalmology for medical students and family medicine people to understand. So I'll see you guys in 5 minutes, okay? Okay, so the second hour, we're going to be talking about high yield ophthalmology for the family doctor slash emergency room doctor. Obviously, this is very useful too for medical students to be able to understand the basics of ophthalmology here. I'm not going to be talking about all the different things that you need to know for ophthalmology, but this is certainly everything you need to know if you're a family doctor or an emergency physician. It's really helpful because, as you know, getting to see an ophthalmologist can take a very long time. So if you're able to better triage and understand the diagnosis that your patients have for their eye complaints, then you will save everyone lots of time. So my objective for this talk is to have a basic approach to the most common ophthalmic presentations in the office, and really to know the ocular emergencies that require urgent referral to us. So for the second hour, we're going to fly through 15 high yield cases. So you got to be really be paying attention, or things will be, you'll be missing out on some of the good stuff. I try to squeeze in as much high yield things as possible because I want you guys to get a lot out of this session. So I hope that you're able to get a lot out of this. I will have questions at the end of every case. Okay, so there's 15 of them. So here we go. Case number one, this is one that we all know now. 54-year-old guy comes to your clinic. He's seeing flashing lights. He says, "Doc, it looks like lightning bolts." So you're going to ask on history. And these are the things that you're going to ask. And the most important thing you can ask here is really, are these flashes in one eye or are they in both eyes? Now, of course, you ask the usual duration, associated symptoms, aggravating, alleviating risk factors, good stuff that I talked to you before. But why binocular versus monocular? Well, that can give us an idea into the differential. Now, everyone's thinking posterior vitreous detachment, but that's only one of the causes for a unilateral flashing lights. This can be inflammatory or infectious. It can be a vascular component like a retinal TIA. When we think of bilateral flashing lights, the most common thing to think about is migraine aura, or some of these other more interesting things. But the take-home message here, again, simplify everything. If someone has monocular flashing lights, it's most likely going to be an eyeball problem, meaning that they need to go into ophthalmology. If they have a binocular flashing lights, it's most likely a brain problem. And they might need to see ophthalmology still, but probably you should think more about any potential neurological causes like migraine auras. Of course, there are exceptions. It's the same for every simplification, but generally speaking, I try and follow as many simplifications as I can, as you may have known, because that helps really simplify my workflow and keeps my brain focused whenever I do see someone with a very weird presentation. The most common types of photopsias we see, so if it's monocular, of course, PVD, like if it's binocular, then it's migraine auras. And when we go back to this case, this 54-year-old male with flashes, now he says, "I also have some floaters." And now, of course, you know that this patient has a posterior vitreous detaching. You also know now that this is a normal aging process, happens to everybody with age to various degrees. Okay, some people may not get any symptoms. Some people may get tons of symptoms. When you send these cases to us for a follow-up, we do a full fundus dilated examination. And what does that look like? Well, if you've never seen us do it, for the family docs and emerge docs here, this is what we do. We take a really bright light, put it on our head, we shine it in their patient's eyes, and then we hold this magnifying glass up to their eye, and we physically look at all the areas of the retina. And what are we looking for? Well, this is what we're looking for. This is my sclerodepression, and when I'm looking in the periphery, I actually see that this patient has some holes. You see that there? These are the little holes that I can see on my sclerodepression bump, and that's what I'm looking for. So these holes will most likely need to be lasered. And what does laser look like? Well, this is what we do too. We basically mount a laser on our head, and then we hold a magnifying glass up to their eyes, and we shoot lasers from our head into their eyes. And then what does it look like afterwards? This is what it looks like afterwards. So this is their previous tears that they had. And these white burn marks are all the lasers that we applied. So these are like hundreds of lasers that I've shot into this patient's eye. And the laser helps to secure the area of torn retina. Okay. Someone asked about when to refer. Well, if they have a high risk feature of, and this is decrease in vision, because someone asked me should someone with a PVD have decrease in visual acuity? No. So if you're 20/20, then you're fine. But if you're saying that this patient is like 2200, they have a visual field defect, I should probably see that patient tonight. But if they are 2020, they are really just having some floaters for a few weeks now. They have some flashes like once in a while. Their vision's great, no visual field defect. Then this can be more of an elective referral. About 1 week, I would say, is completely reasonable. Okay, so no need to rush these patients to our clinic. Please don't send them to the emergency room. It really just bogs down a lot of time unless they have a high risk feature, because if they do, then I'm certainly happy to help you. But if they don't, they're just going to sit in the emerge for 6 hours, get an outpatient follow-up for ophthalmology anyways for 1 week. So just send the referral and they'll be seen and it'll be okay. All right. If someone has a retinal detachment, which is evidenced by the visual field defect, this is what we will see when we look into the retina. You see this area, this is normal retina down here. And on top here, you see that this area of corrugations, that's the area of retinal detachment. And the macula, the center part here, is still on. So that is a mac on detachment. And why do I care about this? Why should you care about this? Is because looking at these two pictures, you would say that the one on the right looks worse, right? And it's true, it is worse. This macula is completely off. But in terms of urgency, what matters is now this area, this eye actually matters much more, because this patient may be, 2200. This patient can still be 2020 right in the center over here. So I want to preserve this 2020 by more urgent treatments. This patient kind of has already lost their chance. And it doesn't matter when we fix their eye, because their vision will not be as good as it used to be. It'll still be decent, but will not be as perfect as it was before. So it's kind of a little bit too late. So in those situations, then, for a mac on detachment, we want to treat them as soon as possible. And if it's a macula off, we can probably do it within a week. And, you might be asking, Mike, listen, I can't look into the eye like you can. How can I, as a non-ophthalmologist, determine whether the macula is on or off? And the answer is in vision, which is one of the vital signs of ophthalmology, checking the visual acuity. If someone's visual acuity is worse than 2100-ish, like the big E or like the second line, then their macula is probably off. And that means that the referral is less urgent than if they had their macula still attached. And remember, this is only in the context of someone with flashes and floaters and a visual field defect. This is not for any patient with changes in their vision. So everything comes into context. And what happens? What is the treatment that they get? Well, when they come to us, and sorry if you don't like seeing needles and eyeballs, but we basically do something called a pneumatic retinopexy, where we take a gas syringe, we inject gas into the eye, and we do tons of these in Toronto. And the gas bubble actually helps to push the retina back. Remember, the retina was all detached before with all that corrugation. Now this gas bubble is helping to physically push the retina back onto the scleral wall. So that's how we treat retinal detachments for the most part here. Any questions about the first case? Could eccentric fixation change the clue that vision gives us to know if it is macular on or off? I can't say I've ever used this before. For me, it's always about flashes, floaters, field defect, good history. If they say I have a field defect and then you check their vision and their vision is hand motion, their macula is off. If they say, doctor, I see a visual field defect and their vision is 20/20, their macula is on. Keep everything simple. No need to worry about eccentric fixation. Any other questions? Pneumatic retinopexy before surgery, or do you mean during the surgery? That is the surgery. So it's not really a surgery. It's like a procedure. Like I do it in the clinic in like 5 minutes. That is the procedure. That is the definitive treatment for most patients. Yes, we can do a vitrectomy. Yes, we can do scleral buckles. But for the most part in Toronto, most of our patients get pneumatic retinopexies, and the success rate is incredibly high for a procedure that does not have any, that we don't need to go to the OR for. Is there a golden hour for saving the retina? Someone asks. I would say that if the macula is on, you have a very good chance of preserving central vision. If the macula is off for more than, I would say, like 4 hours, then you have a pretty good chance of like quote unquote saving the retina. But after that, it's usually not as good. It's not like a stroke where like the damage is done and that you can't recover any vision. We can recover vision. It's just not as good as if their macula was still on. All right, and move on. Good questions. Case number 2, 23-year-old guy, history of contact lens wearer, has increased pain redness photophobia or PRP, because I love acronyms. We all do in ophthalmology. 1 day OD, which is their right eye, after taking their contact lens off. And you think to yourself, is this a corneal abrasion or corneal ulcer? You know, we get referred abrasions and ulcer consults all the time. And many of the times they're accurate, but sometimes they're not. So let's play a game. Is this, and I don't have a Kahoot, unfortunately, for this presentation, but is this an ulcer or an abrasion? Just think to yourself, ulcer, abrasion, okay? Let's look at number 2. This one, ulcer, abrasion, okay? So think about it. Okay, the answer is they're both abrasions. Why? Because you can see the underlying iris detail over the area of concern, meaning that there is no white thing, okay? You know, if you can see the iris clearly, like in this picture, you know, like, yeah, you can tell the cornea is kind of weird, but you can see the iris underneath pretty clearly. Yes, there's a big fluorescein staining in the way, but you can tell that the iris is going to be behind there. You can see that. But when you're talking about a corneal ulcer, you will not be able to see that. And I'll show you what I mean. So this patient has a corneal abrasion. We know about abrasions now because I taught you the anatomy. So you understand that the epithelium is sloughed off. And oftentimes, you know, we want to treat patients with antibiotics. Now, remember, this was a question on the Kahoot where I said that everyone, in my opinion, should get antibiotics for prophylaxis. But, you know, some people in the emerge setting may not be comfortable with giving everyone a fluoroquinolone, so they want to give something else. So feel free to use polysporin drops, tobramycin drops. Any type of antibiotic drop is fine for a week. Why do you not use erythromycin ointment? Well, they actually blur the vision, right? It's like Vaseline. So if you put Vaseline in your eye is going to get all goopy. Patients don't like to be all goopy. So we typically don't prescribe ointment for adults because you don't want to blur their vision more. So you can give them some of them at nighttime, but honestly, it's just easier to give antibiotic drops, not ointment. Okay. Also, very important points. I know that there is a growing body of literature, particularly in emergency medicine literature, regarding dispensing topical anesthesia to patients with corneal abrasions. And the take-home point is that a majority of the symptoms are healed within 1 to 2 days. And in our field, ophthalmology, I have seen personally many cases where emergency physicians have prescribed topical tetracaine or alkacaine or a freezing eye drop for the patient. They used it and then their cornea is melted and they required a corneal transplant. Okay, so someone got a scratch in their eye from something very, you know, like a tree branch, and they ended up needing a transplant because of the fact that someone gave topical tetracaine. Why does that lead to corneal melting? Because tetracaine is actually toxic to the cornea. The cornea actually gets damaged every time you apply it. Obviously, you need to do it when the patient has something that needs diagnosing, but they should not be used therapeutically. Okay, so please remember that you should not do that, even though I know there is growing literature. It's just that we always see the cases that go bad. Now, remember, before it was an abrasion. Now this is pretty obvious, right? This is white. This is a ulcer, okay? And you notice this is the first thing you see, but do you see something else that's white in this picture? And yes, you notice that there is also this area down here, and this is a hypopyon. The hypopyon is inside the eye. This is on the outside of the cornea. This is on the inside of the cornea in the anterior chamber. See, that's why it's so important to understand the words that I'm using. And you remember, because I taught you, that the anterior chamber is between the cornea and the iris, which means it's on the inside of the eye. And a hypopyon is actually a layer of pus inside the eye because of all this associated inflammation from this corneal ulcer. So this is bad. This is an emergency, and we need to see this right away. So take-home message: if someone looks like they have a corneal abrasion, but they have a white thing on their eye, that is an emergency because it's an ulcer and they can go blind. So you need to tell us right away. And you should always presume it's infectious. And please, please, please refer this to me now so I can treat them. Okay. One more thing. If you see a white thing on someone's eye, but the eye is not inflamed, meaning that the sclera and the conjunctiva is quiet. It looks like a normal eye, but you see an old white thing on the cornea, and the patient has no symptoms. Is that a corneal ulcer? Of course not, right? The patient is not in any pain. That could just be an old scar. So you have to put everything in clinical context, right? If you see something white on the eye, and the eye is red and angry, the patient's in pain, yes, ulcer. But if they're not in pain, it could just be an old scar. So always put things in the context. Yes, simplifications are very helpful, but you need to understand what else is going on as well. Okay, so any questions for this case?
Just which abrasions do you recommend referral to ophtho for follow-up?
That's a great question. I think that if it is a simple a corneal abrasion, you do not need to necessarily refer everything to ophthalmology. So if you see an abrasion that's small and the patient's like, yeah, this happened yesterday, it was like 9 out of 10 pain yesterday. Today is like a bit better. It's like 6 out of 10. It's getting better. Those can probably just you can follow that up yourself and as a family physician, or if you're in the emerge, you can send them to their family physician to follow up in about a week. And if they're worse at that point, they can come see us at that point. Okay. All right. Very good. Thank you for your question. If you have a kid with an abrasion, would you recommend a cyclopatch? That's a great question. No, we don't. I don't really recommend patching. It's not. We used to patch people more often for corneal abrasions, but it just it gets better within a day or two. And I think that sometimes the patching can be more traumatic for the child, especially if they're very young. They may be ripping it off, and they may be touching their eyes even more. So I would say not, but there's no harm in patching for a corneal abrasion. Okay, we're moving on. Case 4. So this 63-year-old woman comes in with 3-month history of discomfort in both her eyes. Vision's okay. Eyeball looks kind of red. It looks kind of not super happy. You put fluorescein. You see all these little white dots. You're like, oh my God, is this an ulcer? Then you're like, wait a minute, there's no white thing. So probably not an ulcer. Is this an abrasion? Well, the patient didn't have any trauma. It's been going on for 3 months. I don't know if it's an abrasion. So what is this? Well, this is superficial punctate keratopathy, or SPK. Basically, lots of dots on the cornea. And there's lots of different patterns. It can be diffuse. It can be inferior, it can be interpalpebral, superior, there's lots of things, okay? And it can honestly stay in the cornea, it can stay in the conjunctiva, it can stay in lots of areas. And why does this happen, this kind of superficial punctate keratopathy? Well, this is the most common thing that we actually see in the eye clinic, okay? And if you see this, I want you to think of one thing, okay? Dry eye, okay? There's lots of reasons why this patient may have dry eye. Blepharitis, ectropia, blah, 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 blah. Dry eye, okay? 99% of the time, these people have dry eyes, okay? It's not your job to figure out why they have dry eye, but they have dry eyes. And you can see here that so many dots, okay? And it can look terrible, and you can be super worried about it, but you know what it is? It's just dry eye, okay? These people just have dry eyes, and they really need to lubricate their eyes. So please, please, please start them on some kind of lubrication, okay? Artificial tears, you can use artificial tear ointment, preferably preservative-free. If they're using contact lenses, stop all the contact lenses. And if they really have a large amount of SPK, we might consider antibiotics, but I wouldn't make that decision for your point of view. I would send it to me to make that decision. Yeah. And, a nice little pearl is not all artificial tears are the same. There's preservative-free and non-preservative-free. Preservatives make the drops last longer, but they actually are also a bit toxic to the eye as well. So if you prescribe someone a non-preservative free artificial tear, or you recommend to them something like Systane, those should only be used 4 times a day, because any more can lead to toxicity. Okay, so take-home message of this case is that if you see a lot of staining, little dots everywhere, that means that it is probably dry eye. And this is rarely an ocular emergency, almost never actually. And really the treatment is to treat the dry eye, lubricate like crazy, and they're going to be okay. But it can be really bad. Their vision can be down. They can have a lot of pain, but it's mostly going to be dry eye. Any questions? Perfect. Moving on. Flying along here. Case 5, 56-year-old female coming into the office with discomfort in both eyes, irritation, some blurring. She's going on for a while, not really specific. And you'll be wondering, why am I showing you this again? Isn't this just SPK, superficial punctate keratopathy? I know this, Mike. Why are you showing this to me? Well, I'm just gonna hammer home the point that this is like the most common thing that will come to your emergency room or to your clinic, because dry eye is everywhere. It's rampant. Everyone will have this, and I want you to see it now, so that when you see it on your slit lamp, you won't be surprised that it can look this bad. What does this patient have? They have the bane of my existence. One of the banes, it's blepharitis. Blepharitis is inflammation of the meibomian glands that are in the eyelid. You see how thickened these eyelids are? That's not normal. It's because of the inflammation of these meibomian glands of this eyelid. Then on the eyelashes, there's all this crust that's like literally lining their eyelashes from this blepharitis. And you can see here a comparison between normal and blepharitis is that this normal side looks great, but this blepharitis has all this meibomian gland inflammation. They have these scales and debris looking not so happy. And actually, you can actually see these clogged meibomian glands. And if you push on them, which I do, you can actually express them like toothpaste. I can push out this gross clogged meibomian gland stuff. And this is all going to be to do with blepharitis. And the treatment, warm compresses, more warm compresses. You need to be able to use the warm compresses to heat these meibomian glands and dilate the meibomian glands so that all that oil and gunk can leave the meibomian gland. There's other stuff that I love telling people about: lid hygiene, omega-3 fatty acids, artificial tears, PO, oral doxycycline if it's refractory, but you should never prescribe this. But that's something that I would do. So you can tell them to use warm compresses. What do you mean warm compresses, Michael? Well, on Amazon, and I have no financial interest in this product, but this is an example of a very cheap one for $9. That's this reusable therapy mask, and you can heat it in the microwave for 30 seconds or whatever, put it over your eyes and keep it on for 5 minutes. And I tell patients who have blepharitis to do that at least twice a day. And it's going to get better, but it's going to take like a month to get better. Okay. Questions for this one? Good. Moving on. Number 6, flying along here. Is this the same thing? Is this just another inflamed meibomian gland? You guys know this now. Blepharitis, right? Is that the answer? Well, it looks a bit more red. It looks a bit more edematous here. It looks more localized too, not as diffuse. And what's the diagnosis here? Well, this is a sty, a chalazion. Goes by many names here. And again, if you look close, this patient also has the crusting on their eyelids. And this is what happens when blepharitis can lead to a chalazion. So blepharitis, you remember, is the inflammation of the meibomian glands. If these meibomian glands get completely clogged and have no way of expressing, then it can become very acutely inflamed and can lead to localized inflammation. And that can cause that sty that you see over here. So this is probably one gland that got so inflamed and blocked off that it's causing such a massive reaction. And the treatment sometimes is actually an incision and drainage, where we actually flip the eyelid. So this is the eyelid that's flipped, and we use a blade to cut open this area of meibomian gland and to express all the pus. We do it all the time, and I love doing it. However, there is a right time and a wrong time to do it. So in the acute situation, it's actually wrong to do an IND because the eye is very hot. And, when things are hot, they're more likely to scar. And when things scar, they close off. So basically, if something's hot and I do this procedure, that cut is going to seal up right away. And that's a waste of time. Do not send these patients, these chalazions and styes, to ophthalmology for incision and drainage until they're very chronic, until the eye looks quite quiet, but the bump is still there. So if you see a bump, but the eyelid is not red and the patient's very, upset cosmetically or whatever, then send them to us and we're happy to take it out at that point. The treatment otherwise is to warm compress the crap out of this. Like literally, if someone has a chalazion, I tell them to put that warm compress pad on their eye like 8 times a day for 5 minutes at a time, because the heat is really going to help open that meibomian gland up and express the chalazion naturally. The usual stuff that I talked about before for blepharitis still applies. And the Tobradex drops can be prescribed, but again, I would leave any prescription of most antibiotics and steroids to ophthalmology. Antibiotics you can do yourself, but if you're ever adding a DEX component to it, I'd probably leave it to us to do, because there are a lot of side effects for steroids, topical steroids that you don't want to deal with, like cataracts, glaucoma, not fun stuff. Okay. Take home message for this case is warm compress is king. Like literally, if you get chalazions, that's fine. Use warm compresses 5 minutes a day, 5 minutes at a time, like 8 times a day, and then it will get better. It just takes a lot of time, like weeks. Okay. So I would say that, in my time as a resident, I've seen like, I can't imagine how many of these, like 100 probably or more. And I would say that the vast majority of them, about maybe 80-90%, are treated with just warm compresses. So this is the treatment. I&D we only do after conservative management. Questions?
Just for internal styes, do they need systemic antibiotics?
Nope. We rarely ever prescribe systemic antibiotics. Like Keflex, for example, like you might be worried about a cellulitis. We do not prescribe oral antibiotics for these because they are not infections. They are just kind of inflammation. And the reason why Tobradex works is because they have there are other bacteria that can cause super infections around the skin flora of the eye, and we want to prevent that, not to directly treat the chalazion. And someone asks, is chalazion and sty the same or the different? There's like nuanced differences to them, but for my purposes, I think of chalazion and sty the same thing. Sty is more colloquial, but it's the same. Okay, good questions. Moving on. Case 7, 26-year-old female has a history of rheumatoid arthritis. That should probably trigger something in you. So think about badness, why this young patient has rheumatoid arthritis. That's probably not good. Painful, right red eye. Okay. So you look at this and you're thinking, okay, that's probably going to be either scleritis or episcleritis. And now think to yourself, which of these conditions is associated with a systemic disease? Is it episcleritis or scleritis? Answer is scleritis. How do you differentiate this on history? Because they're both red eyes. Well, scleritis will have this excruciating deep pain. And when I say excruciating, I mean like these patients have so much pain that they need to be admitted to hospital, like under guidance of the pain service because they're in so much pain. So if they're saying like, oh yeah, my eye's a bit irritated, a little bit scratchy, that's not deep, severe pain. These patients are like, I want to like rip my eyeballs out of my head because it's in so much pain. That is the deep, severe pain of scleritis. And obviously, about 50-60% of the time, they are associated with a systemic disease like rheumatoid arthritis. So they do require a systemic workup. That being said, though, if you have someone who's already diagnosed with rheumatoid or granulomatosis is polyangiitis, then the diagnosis is likely going to be scleritis. Okay. These are some pictures of of eyes with scleritis. And we actually look at these eyes not at the slit lamp. This is just like shining a light on their eye, like an iPhone light, looking closely at their eye. And you see that this bluish tinge. You see that bluish tinge over here and over here. That's associated with scleritis because the eye is so thinned. The sclera is so thinned. You know what this bluish tinge is? You're looking at the uvea. You're actually seeing the uvea underneath the sclera. Remember the uvea? That's the red layer underneath the black layer. That you're actually seeing that because of how thin the sclera is. So that's scleritis. Another good trick is that you can get a cotton tip and try and, after you numb the eye, you can try and move the vessels with a cotton tip. If the really red angry ones are moving, that means that it's probably episcleritis because those episcleral vessels are more superficial, whereas the scleritis is for these superficial and deep vessels, and deep vessels will not move. So you can try that in the clinic if you would like to differentiate. But personally, I find history more useful than physical examination for these cases. Episcleritis, though, can look quite bad. And this is just to remind you that even though it's the less severe of the two, this eye looks very angry still, as does this one. But these patients will not have that deep pain, usually do not have an associated systemic condition, and they require less treatment. What is that treatment? Well, episcleritis gets treated with artificial tears and NSAIDs, whereas scleritis gets treated with NSAIDs and systemic therapy, i.e. prednisone orally. So it's a big deal diagnosis to make this. Definitely an emergency. So remember, scleritis associated with systemic disease like our patient with rheumatoid, violaceous hue that you can see on gross examination. Episcleritis treatment is conservative, usually with oral NSAIDs like naproxen or Advil, excuse me. And scleritis definitely deserves an urgent referral to us if you think it is. Okay, questions. Would you give topical steroids for scleritis? You usually could. It depends. That's a really good question. I will say that the mainstay of treatment is systemic, and that is probably the most useful treatment for them. You can use topical steroids certainly, but it is not the mainstay of treatment. And another question is, what about using phenylephrine to check for blanching for episcleritis? That's good, yeah. So this medical student, I think, is trying to tell us that you can use phenylephrine drops, which helps to constrict the superficial vessels. And then after you put in phenylephrine, you can take a look before and after, take pictures, obviously. And then you see that if after it's much less red than before, it's most likely going to be episcleritis. That's true. You can do that. But like I said, history for me is still king for these diagnoses. And the second question is, does systemic or just corticosteroid drops increase risk of cataract or glaucoma? That's a great question. Actually, systemic steroids do not really increase your risk of cataract or glaucoma. It's actually just the topical steroid drops that increase the risk of cataract and glaucoma. It's not the oral. Okay. Would you need a fundus examination for every scleritis patient? Absolutely. You need to look at the back of their eyes, make sure there's no inflammation inside their eye, on the retina, or of other structures, because scleritis certainly is a type of inflammation of the eye, and you want to do a full exam for every patient regardless. So every patient gets a fundus exam no matter what. Okay, good questions. Case 8, 65-year-old vasculopath presents with sudden onset vision loss for 5 hours. And we're not going to talk about the approach to vision loss here, okay? Because, anytime there is acute vision loss of any kind, that is a red flag. That means that there is a referral to ophthalmology that needs to be made, okay? So I'm not going to go over how to think about every single cause of sudden acute vision loss because there's way too many, but I want you to think of some of these concepts to help illustrate a point for patients that present with acute vision loss. The first thing is you have to check an RAPD in every single case of acute vision loss, okay? Because if you find an RAPD, that's bad, first of all. And secondly, you know that there is an objective problem of either the optic nerve, the macula, or the retina. These are some examples. And the question I'm asking here is, do these vitreous hemorrhages or cataracts cause RAPD? Just think about that for a second. Does a vitreous hemorrhage or cataract cause RAPD? No. They do not, because they're not optic nerve, macula, or retinal dysfunction. How about a small retinal detachment? Usually also not, okay? It can, but usually not. What do I mean by RAPD? Look at this picture here. Just look at it. The arrow is the flashlight. So when the light swings from to the right eye, it constricts. And then it constricts as you point to each eye. And then a slight dilation afterwards, which is normal. This is a normal test, okay? So flashlight here, slight dilation. Immediate constriction, slight dilation. Immediate constriction, slight dilation. Normal RAPD, okay? This is not a normal RAPD. So as the light goes from eye to eye, normal constriction, slight dilation. Immediate dilation. Normal constriction, slight dilation. Immediate dilation. See, so this left eye is where there is an RAPD, okay? So really try and understand RAPD because this is a crucial examination technique that you have to know how to do successfully. If you if you're not confident for an RAPD, there are other ways to check. You could actually use color vision. So you can test each eye separately, and you can either check with, you can show the patient the color red, and in the good eye, they'll say this is a very rich red. And then in the affected eye, they'll say the red is, more like of a darker burgundy color, or it's not as bright, because a red desaturation is indicative of optic nerve dysfunction. You could also get some color plates and to check their color vision. Now you say, Mike, listen, stop. I don't have any color plates. I'm not going to buy color plates. That's okay. There's a free app, Eye Handbook. Okay. You can use it and download it, and you can actually test someone's color vision. Look at this number, it's 15. If you can't see that, you probably have red-green color blindness, which is fairly common in the population, about 5%. So it's 15. So a case to look at the utility of RAPD and color vision. This 65-year-old male who has acute vision loss for 5 hours, also has a history of jaw pain and headache. And we were asked to rule out GCA, giant cell arteritis, the real badness here. And when you examine this patient, you see that they're 2200. You're like, oh crap. But then you check the REPD and you're like, that's weird. They don't have any REPD. And you check again. You're like, I'm pretty sure they don't have one. And you don't see it. Check the normal color vision. You show them the red, whatever color, something red in the emergency room. You show them, the color plates. They can kind of see the numbers kind of okay if they hold it really close to their eye and they see all the numbers properly. And then you examine them here and you look at them. You're like, wait a minute. Why is this eye have this white thing here? And that, of course, is a cataract. So, can someone present with acute vision loss with a cataract? No, unless they have sudden realization of monocular vision loss. So let's say this guy, his right eye is 20/20, left eye is 2200, but because his right eye was 20/20, he can go around his life living normally and never have noticed that there's a problem with his left eye until his right eye was accidentally blocked by his hand while in bed, like whatever is blocking his right eye view, and then only his left eye is seeing, and then he suddenly notices that his left eye vision is not good. That is what we mean by sudden realization of vision loss. So he may think that it's sudden vision loss to him, but there's no way this cataract formed in 5 hours and is causing that vision loss. How do we know that this is not something more serious? Because he didn't have an REPD. That is how you know, okay? So the bottom line here is that for vision loss where the cause is not obvious and where it's difficult to examine the retina, history is the most important. And always check for an REPD, because if you find one, there is something very wrong. If you don't find one, then there could still be something wrong, like a cataract, but it's nothing wrong like can threaten the patient's life and vision permanently wrong. I'm going to quickly digress into giant cell arteritis, which is a very bad thing. This is a medium to large vessel vasculitis, which only occurs in patients who are over 55. So this is how I think about GCA. Okay, listen. It is a vasculitis. That means that it affects blood vessels that supply blood to the eye. It is a vasculitis, which means that it can affect blood vessels in other parts of the body, which means that it is a dangerous diagnosis to have. And, for us, when GCA affects the blood vessels that lead to the eye, the blood vessels can become occluded, and that can lead to vision loss. But you can also have these other symptoms: headache, jaw claudication, scalp tenderness, proximal muscle jaw aches, blah, blah, blah. So that's why it's important to think about that. And patients with GCA may have some previous episodes of transient vision loss. They may have intermittent diplopia. They can have normal ESR, CRP. Is that normal? No, but it's possible. And they can develop vision loss in their other eye, meaning that they can go permanently blind. So this is very important to make sure that you always think about this. And the take-home point for this case is that you should really, when someone is over 55 and there is an REPD, order ESR, CRP. Even if it's normal, it doesn't rule out the diagnosis, but you can be fairly certain that they don't have it. We treat them with steroids to prevent vision loss in the other eye, and GCA can present without ocular symptoms. So if you think they have like jaw claudication, scalp tenderness without ocular symptoms, rheumatology should also be involved as well. Okay. Any questions here? Nope. Okay. Went along here. Case 9. 29-year-old with some redness, itchiness, vision is okay. No URTI. You look at them and you think this is viral conjunctivitis, also known as the bane of our existence. Why am I talking about this? Not because it's an emergency, okay? That's not why I'm telling you about this. I'm telling you about this because it is not an emergency. This is a disease that gets treated and managed conservatively, okay? Even though they think that this, you may think this patient looks terrible. They're like so much discomfort. Like honestly, these patients are so unhappy. They actually just need some hand holding. Actually, probably not, because they're contact and very contagious, but you need some like metaphorical hand holding and some cool compresses and, let them be. If it's bilateral, okay, it has been happening, one eye then the other, it is almost certainly going to be viral conjunctivitis. So if they've had a history of URTI, if their sister and brother have it, if they say, doc, it started in my right, went to my left, viral conjunctivitis, please don't send it to us. Why not? Because they'll come to our clinic, someone examines them, they touch everything, other patients touch things, the whole clinic gets viral conjunctivitis, and you can knock out an entire eye department in a hospital, which has happened before in Toronto. So please do not send these patients to us. They will do just fine. How do you know that they have it on your examination? Well, you can look for it by the vision being okay. They're not going to be 2200. They're going to be like 2020, 2040. They're follicles out here. So you see these? These are follicles down there, and they can have some discharge. They can have some preauricular lymphadenopathy. Here's another picture of follicles. Okay, here's another picture of really big follicles. Like I don't know if you've ever looked in your eye before, but this is not normal, obviously. And they can also get some subepithelial infiltrates, which are these white little dots on the cornea that can cause vision problems. But really, these may need to be treated more aggressively, but generally do not. And I'm going to show you some more pictures, okay? You look at this, you're like, wow, Mike, that looks terrible. Can that really be viral conjunctivitis? Yes. Look at this picture. Oh God, why does all this mucus and the gunky discharge? No way this is viral conjunctivitis. Yes, it is. It could be viral conjunctivitis. Oh my God, there's no way this is viral conjunctivitis. There's like blood here, blah, blah, blah. This looks like a trauma. Okay, no, this is actually a hemorrhagic viral conjunctivitis. Okay, this picture here, can this possibly be viral conjunctivitis? No, this was not. You know why? Because this is actually a globe rupture, because this patient has a misshapen pupil over here. Obviously, there is going to be a history that this patient got some kind of trauma, right? Like obviously, if you're viral conjunctivitis, you're not going to have trauma. So most of the time, anything that looks bad in one eye than the other can indeed just be viral conjunctivitis. Okay. So what is the treatment? Just think about this. Should we send it to the eye clinic right away? Should we start them on antibiotic drops and then send it to me? Oh, that's a good one. Should we start them on some artificial tears and antihistamines, cool compresses, avoid people? The longest answer and C in multiple choice questions are usually the correct answer. So that's what I'm going to pick. And that is the answer. Okay. So this is the answer for this treatment. They should get better in 3 weeks. If they don't get better in 3 weeks, then I'll see them. But do not send it to us acutely, please, for the love of everything good. Or like other conjunctivitis, we have viral, we have bacterial, allergic, classic, med school, primary care treatment. Bacterial is usually one eye. Allergic is usually both eyes with plus itchiness and a history of atopy. That's how I think about other conjunctivitises. Okay. And my treatment regimen for these is if they have bacterial conjunctivitis, I use a fluoroquinolone drop 4 times a day for 7 days. Why a drop? Remember, ointment blurs visions. Don't give them ointments. And for allergic conjunctivitis, mainly cool compresses, some mast cell stabilizing drops, which is called Pataday, artificial tears, and an oral antihistamine. Something over the counter usually works fine. And for this case, not an emergency, but viral conjunctivitis is very contagious. So many take-home messages here. Treatment is always conservative, okay? So if you think it's viral, it's most likely going to be viral. And eyes with viral can look horrible, as I've shown you. They can look absolutely terrible. And the vision is usually okay. It may be a bit worse if there's some corneal involvement, but nothing that needs to be emergently treated anyways, okay? Some other questions that came up is for bacterial versus viral, is the mucopurulence the key? The key is that it's unilateral. I've almost never seen a bilateral bacterial. I've actually never seen a bilateral bacterial conjunctivitis before, except in neonates. So besides neonates, most adults will not have a bilateral bacterial conjunctivitis. It's almost certainly going to be viral or allergic. Okay, great. Case 10, moving along. 35-year-old female, pain, redness, photophobia. So photophobic. This is the one that you guys know. And on your examination here, you can see that the slit beam, you can see, look here, what do you guys see those little dots over there? And I know many of you guys don't have access to a slit lamp if you're in the emerge setting, but the reason why I touched on this topic is that uveitis is quite common. So it's very important to know. And if you're a medical student interested in ophthalmology, you have to know how to do this. The slit beam, you focus it on the areas between the slit beam here, and in the black, you can see that there's little dots. And this is a spot diagnosis for sure. Zoom in here, you can again see those little dots here. These are the cells that are floating inside the anterior chamber. Remember that this is not normal and is never normal, because the eye should always be deep and quiet. So you should never be able to see cells. If you do, they have inflammation. Some tips: make sure that you are using the brightest light setting on the slit lamp. Put the beam at 45 degrees. Use the pupil as a black background. and focus on the iris and then pull back to get into the anterior chamber. So this is the space in the anterior chamber. This is the light of the cornea. This is the light that hits the iris. Remember, the space between the cornea and the iris is the anterior chamber. You're looking for anterior chamber cells in the anterior chamber. So that's where you're going to look. Other interesting bits that you may or may not know, that uveitis can present with low IOP. That's why we like to check pressure in the emerge when we can. Photophobia is the number 1 symptom. They can have something called posterior synechia, which is basically this misshapen pupil, and can often be caused by the herpes virus, actually. And this actually causes high IOP. So a little bit more information than you may need, but if you're going into ophthalmology, you obviously have to know this. And really the hallmark is photophobia. If someone has light sensitivity, in my experience, it's one of 2 things: corneal abrasion or iritis, okay? And obviously uveitis is not going to have a history of trauma for the most part, whereas corneal abrasions do. So if someone comes in with photophobia, it's going to be one of these 2 things. Number 11, chemical injury. 35-year-old guy, he has, some kind of injury, and then, he comes to you. These are 2 different eyes of 2 different patients. But if you saw this eye versus this eye, which eye would you be more concerned about? Just think about it. This one or this one? Most people would say that they'd be more worried about this one, but actually this eye is not normal. This whitening is actually destruction of all the vessels. Like you can't even see any vessels at all, which means that this eye has been so damaged that all the vessels have been destroyed. So that's not good. When you look at these injuries, the 2 most important things is the type of chemical and the elapsed time before irrigation has begun. Okay, so try and figure out what they got in their eye, if it's acidic or basic, and then how long that crap was in their eye before someone had the smart idea to pour water in their eyes. That's for prognostication, because bases are bad. So if someone has acid in their eye, it's less bad than bases. There is a whole biochemical thing for this that I won't bore you with, but you should understand that if something's basic, it's probably worse. You should treat them with irrigation. Just do it. Like if you are thinking about should I put a Morgan lens in and irrigate? Just do it. There's no harm unless you cause a corneal abrasion by putting in your Morgan lens to irrigating someone's eye. So just put the Morgan lens in and run 1 liter of normal saline or 2. If you ran 2 liters of normal saline, I can almost guarantee you that the pH will be normal by the time you finish 2 liters of normal saline. Okay. So you can never go wrong with over irrigation, and please refer to us and we'll help you there. Any questions? Nope, we're good. All right, we're getting towards the end. Diagnosis here. What is a spot diagnosis here? Well, we can see here that this patient in A, the patient's trying to close their eye. The right eye looks like it's closing pretty well. Left eye looks like there's some areas where it's not able to fully close. When they're able to smile, the right side is smiling well, left side is not. And then if I told you that there's no other causes, then this diagnosis, of course, is Bell's palsy or 7th nerve palsy for some reason. Why do we care about 7th nerve palsy? Well, look at this eye that's so exposed. This can lead to something called exposure keratopathy. That can lead to this. The cornea can be damaged because exposure to the surface, to the outside environment, because of all that water evaporating, because we don't blink or close our eyes, can lead to this disgusting picture of what can happen if it's untreated properly. So please let us help your patients and refer these patients to us so that we can help co-manage them. Do we need to see them today? Obviously not. You can start them on artificial tears, but we do need to see them eventually. And these patients can get ointment. They should get ointment, because I care less about how well their vision is. I care more about the fact that their eye needs to have some kind of gunk on it, like some kind of medicated gunk on it, to prevent moisture from evaporating. And we usually use tear ointment every 4 hours. So that's like about 6 times a day. Okay. Question? Are there any chemicals that would react with tetracaine? That's a great question. I would say in my experience, no. So you're always safe to put in tetracaine in the eye to help with patient numbing before you put a Morgan lens in. Is proviodone iodine used for vital conjunctivitis? That's a really good question. In Canada, we do not regularly use proviodine to sterilize the eye, but I do know of some practitioners in Canada, some cornea specialists that like to do that to help get rid of the kind of the bacterial viral load on the eye. But I would say in general, no. In general, we just let it treat conservatively. But I do know that there are places in the world that do this. So that's a good question. Do we want all Bell's palsies referred to us? No, I mean, that's like, it may be hard for you to assess sometimes. So I think that if they have Bell's palsy and their eye looks like this, so in panel A, I would want to see this patient. If they are able to completely close their eye such that it looked like this, then I do not want to see that patient. But if it looks like this, then we should see this patient. So if they close their eye and you see the white of their eyes, that should be referred to me. Is it enough for us to tell the patient to tape their eyes shut? That's a really great point. You know, if you're in a more rural setting and you're like, ophthalmology is like 2 hours away, do I really have to send them there? No, of course not. You can tell them to use ointment 4 times a day and tape their eyes shut. Just make sure though that they're taping their eye shut properly, because if they don't, then the tape can be touching the surface of their eye, which is ultimately much worse than them not having tape at all. But yeah, certainly they can tape their physical eyelids shut as a means to maintain moisture. Very good question. Thank you. Case number 13. What is this diagnosis? Patient has no history of trauma. Think about it. Think about it. Subconjunctival hemorrhage. Okay. This is nothing. It's a bruise. Okay. That's it. Period. This is not even the worst one I've seen. I've seen ones where there's so much bleeding that like they cannot even close their eye. But vision 20/20. No pain, no symptoms. And if they're on a blood thinner, do you think we should stop this? Obviously not, or else they're going to die. So do not stop this blood thinner for a little bruise on their eye. This is going to go away by itself in 2 weeks. Give them artificial tears, lots of reassurance. They're going to be okay. All right. Almost done here. We have a 47-year-old female. I know I'm going a little bit over time. Please forgive me. Who has a history of HSV keratitis, and they come in and look on their cornea and you see this beautiful, nice dendrites, okay? And what you can do for these patients is before you put in topical anesthesia, you can actually get a cotton swab and touch their eye with a cotton tip, and that will assess their sensation, because when you have herpetic disease of the eye, that actually can present with decreased corneal sensation. We actually do this in clinic. I take a little cotton tissue paper and gently dab their eye. And if they don't blink, like this patient is normal. If they don't blink, like this is a blink. If they don't do this, it means that they most likely have something herpetic, or you accidentally put in topical anesthesia already. If they have HSV keratitis, the main treatment is oral antivirals, either Valtrex if they have insurance, or acyclovir if they do not. Never use steroids, and these do not need to be seen urgently. Okay, like the most important is you start antivirals, and then we'll see them, you know, in a few days. Like this is fine. This is similar. You know, this is another type of herpetic disease. We see that it is more following a dermatome. There is a little dot here on the nose, and it's a classic sign that most medical students and emergency medicine people get pimped on. It's called Hutchinson sign, and this is because of the nasociliary branch of V1 gets involved. The nasociliary branch backtracks onto the cornea. So if you have involvement of the nasociliary branch of V1, that means that the cornea also gets can also be involved as well, which is why you refer it to us. When we check the check the cornea, we see the pseudodendrite formation, which looks like a dendrite, but not really. So that's why it's called a pseudodendrite. And then we will treat them with antivirals. We use them twice as much as the HSV dose. Remember to double the dose of oral antivirals. And if you think, should I refer this to ophthalmology? If they don't have Hutchinson sign and their eye is not red, they probably don't have any infection in their eye, right? You think about this, you can't really have infection without the signs of inflammation like rubor, all that Latin stuff, whatever. You know, if their eye is white, it's not red, it's not going to affect their cornea most likely. So they probably don't need to see us. They need oral antivirals though. You do not give steroids, obviously, and their corneal sensation can be reduced. We should probably see them for outpatient follow-up at some point in a week or so if their eye is white. If it's red, probably see them in a couple of days. Question, topical or PO antivirals? So we in Canada do not really have access to topical antivirals. So we use PO antivirals for all cases of HSV and VZV. There are cases of compounding pharmacies that can give antivirals, but often we don't like to, we don't have access to that, or patients don't have access to that. Plus topical antivirals are toxic to the cornea, so we don't want to give more toxicity. So we use oral antivirals, okay? So I know that was a lot. I want you all to just pay attention one more time. I'm going to go through all 15 cases again and give you the one tip from every single diagnosis, okay? So just pay attention for like another 2 minutes, and I swear to you, you can go. Flashes and floaters, okay? Most common cause of monocular flashes and floater is a PVD, a normal thing that happens in the eye. 10% of patients who have a PVD can have a tear, and that's why every PVD, should be referred to see us, but, in 1 to 2 weeks, unless they have decreased vision or a visual field defect, then we should probably see them within 1 day. Corneal abrasion versus ulcer. On the left is an abrasion. Why? There is no white dot. On the right is an ulcer. Why? There is a white infiltrate and the eye is very red and angry. Also, a little bit of hypopyon here. Dry eye, bane of our existence, looks terrible. Lots of green, superficial, punctate keratopathy, SPK. Treat them with preservative-free artificial tears. Okay? When I see punctate staining, I think to myself, dry eye 1,000 times before any other diagnosis. Blepharitis, inflammation of the meibomian gland. You need to use warm compresses. A warm towel is not enough. It goes cold in like 5 seconds. You need to have something more substantial, like these little like rice balls or beads or whatever that can maintain heat for like 5 minutes. Okay, so get them to use this for 5 minutes, multiple times a day. Styes, one meibomian gland that got really blocked and inflamed, also treated with warm compresses many times a day, and can take up to 1 month of treatment to get better before we even consider drainage anyways. Scleritis versus episcleritis. Scleritis is bad. These people have lots of pain that wakes them up from sleep. They may need to be admitted, and they probably have something systemically wrong with them. They're going to get oral steroids and may need some other immunosuppressive medications orally. This is a violaceous hue from thinning of the sclera where you're physically seeing the choroid underneath. That's not a good sign if you're seeing someone's choroid. Acute vision loss is obviously bad, and you need to refer to ophthalmology or send them to the emergency room if you're not already there. And you should always think about GCA in patients who are older than 55, never in anyone that's under 55, because there's been like scarce case reports of them. So don't tell me this 27-year-old with acute vision loss has GCA. They do not. This is an inflamed temporal artery. Viral conjunctivitis is not an emergency. It looks horrible. This is viral conjunctivitis. This is like a very extreme example, but if it looks like it and smells like it, it is it. So treat conservatively, and we will see them in 2 to 3 weeks, not today. Uveitis is someone that presents with significant photophobia and red eye. It is certainly the hallmark, and you understand now the anatomy that I taught you before for uveitis. Ocular chemical injuries. This is bad. Probably caused by a base, because bases are bad, worse than acid. Please treat them early with irrigation and put a Morgan lens in their eye and just irrigate them. It's going to be okay. Bell's palsy. I should put a picture of Justin Bieber, although he technically doesn't have Bell's palsy. He has Ramsay-Hunt syndrome, which is another cause of 7th nerve palsy caused by VZV. Anyways, you should refer to us to make sure that there's no exposure keratopathy, especially if they cannot close their eye. Subconjunctival hemorrhage is a bruise, period. It will get better. It can look like this, truly. Now, I will say that if someone comes to you with this picture and they say, "Doc, I've been punched in the eye by someone wearing like metal knuckles," obviously this is not just a bruise, and they need to be seen by us to make sure they don't have a globe rupture. But if someone is like, "I'm just walking, and then my daughter told me that my eye looks like this," it's probably a subconjunctival hemorrhage. Just relax. They're going to be okay. Don't stop their blood thinner, please. HSV and VZV are basically viruses that can affect the eye. These viruses, unlike viral conjunctivitis, meaning viral, when I say viral conjunctivitis, I mean like adenovirus, like some innocuous, like run-of-the-mill virus. These are not run-of-the-mill viruses. These are bad things that can cause people to go blind. So you do need to treat these with oral antivirals of acyclovir or Valtrex. And remember that VZV is double the dose of herpes simplex. Okay, so that was my 13 quick run-throughs of all the most common diagnoses that you should be expected to see. If you have more questions, this is the Will's Eye Manual, which is an amazing compendium and a good office and emergency room book for mainly ophthalmology people. But I have met family doctors and emerge docs who have the Will's Eye Manual. So a little pitch for that. And if you're more interested in learning the clinical skills, I really highly recommend you to go to timroot.com. He is like an amazing guy that like makes all these amazing videos and taught me a lot when I was a medical student. Okay, so thanks very much for your attention. I'm very sorry I went over. I hate when people go over time, so I hate myself today for going over time. Please email me if you have any questions. And thank you very much for your attention and staying here and listening to me. I think that there's two winners. Who are they?
Yeah, so I think they're in the chat now. Iris and Anonymous, you guys are the winners. So if you have your screenshot from earlier, you can send it to the COSIC email, which I think Anne has posted in the chat there. We also wanted to ask you all to complete this quick survey. It takes like literally less than 1 minute, but it really helps us just get some feedback on how the lecture was and how we can improve these sessions for next year. So there's a link that should be posted in the chat. There's also this QR code here. So we'd really appreciate if you can fill that out as well. And I also just want to thank Dr. Nguyen for taking time out of his afternoon to come give us this lecture today. He's actually one of the few returning lecturers from our first iteration of VISCO, just because his introductory talk to ophthalmology is just so excellent and really provides us with a good basis to go into our future sessions over the course of the summer, with our next one being on OCT, which is an imaging technique that's really common in ophthalmology nowadays. That'll take place next Sunday, same time, and we'll be sending out a link for that session as well. So once again, just wanted to thank Dr. Nguyen for giving the talk today. Thanks to all of you for coming out to our first session of VISCO this year. And we hope that you'll make it out to our future sessions this summer as well. So with that, if there isn't any other questions, I see, yes, certificates will be distributed at the end of the 6 weeks and we'll include on there how many sessions you've attended as well. So